this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
So good morning, everyone, and thanks for being here. My name is Haneen. I am the current PGY2 EM resident at Advocate Christ Medical Center here in Chicago, Illinois. And as mentioned, we're going to be talking about the use of steroids and septic shock. To start us off, I have no conflicts of interest to disclose. So sepsis impacts more than 1.7 million Americans annually, with an associated 30% or greater mortality risk in those who advance into septic shock. There's been an associated about 10% mortality increase for every additional organ involved. As we know from the evolution of literature surrounding septic shock in the past years, there's been mortality benefit that's been proven with time to antibiotics, with a preference of getting those antibiotics in within the first hours, especially patients with septic shock, fluid resuscitation, and vasoactives. There's also been a proposed benefit with a lot of other resuscitations, such as fluid resuscitation and vasoactives. Proposed benefit with adjunct therapies such as early goal-directed therapy, or EGDT, and the use of vitamins such as thiamine and vitamin C, which were a proponent of HAT therapy, initially showed some promise, but as more literature assessed their benefit, they kind of fell out of favor given the lack of benefit in patients with sepsis and septic shock. I'd argue that steroids kind of fall somewhere in the middle, with literature to support its use for faster time to shock resolution, but very limited literature on its mortality benefit in patients with septic shock, which is kind of what we're going to be discussing today. I wanted to very briefly cover the pathophysiology of sepsis and shock. So as we know, sepsis is a severe dysregulation of our body's response to an infection, which leads to the activation of pro-inflammatory mediators. The activation of these pro-inflammatory mediators leads to vascular and endothelial cell injury. These injured cells allow for granulocytes to enter the inflamed cells, which then further your cell damage. So this, in addition to the release of our vasoactive mediators, such as your prostacyclin and your nitric oxide, lead to capillary fluid leaks, suppression of our autoregulation of blood flow and perfusion, which leads to vasodilation, a decrease in our preload, and worsening hypotension, all of which leads to worsening of shock. Additionally, these patients are going to be in a procoagulable state as a result of their impaired anticoagulation mechanisms in the coagulation cascade, such as via the activated protein C pathway. The benefit of steroids in septic shock comes from their anti-inflammatory mechanisms, such as the inhibition of nitric oxide, correcting any adrenal insufficiency that may be the result of sepsis, and reducing our pro-inflammatory pathway markers, such as your interleukin factors. All of this will lead to vasoconstriction. Glucocorticoids additionally can actually lead to fluid retention, which is going to increase our volume and increase our blood pressure, hence the benefit of hydrocortisone in septic shock through its mechanism as a glucocorticoid. The proposed added benefit of mineralocorticoids is due to their biological activity of interacting with the intracellular mineralocorticoid receptors, which are found in multiple places in our bodies, including our vascular smooth muscles, endothelial cells, macrophages, and neutrophils. The activation of these receptors increase our leukocyte adhesion and production, increasing our TNF-alpha and reactive oxygen species. There's also a suggestion that patients with sepsis have low plasma aldosterone levels already, so it's possible that the mineralocorticoid pathway is more impaired than the glucocorticoid pathway in this pathophysiology. Hence, the suggestion that homeostasis might be best achieved if we add fludrocortisone to hydrocortisone. Another thing that I'd like to denote here is the difference in administration of your agent. So hydrocortisone can be given IV, which is going to be excellent bioavailability. However, the PO administration of fludrocortisone is going to be less than ideal, given that these patients are already in a shock state, so absorption is likely going to be low. In the 2016 guidelines, the recommendation for use of steroids was against the use of steroids in patients with septic shock who were able to be resuscitated appropriately with fluids and vasopressors, caveating that if these patients were refractory to fluids and pressors, you can consider IV hydrocortisone. This was identified as a weak recommendation with a low quality of evidence, but in the newer 2021 surviving sepsis guidelines, they actually recommend and suggest the use of IV corticosteroids in patients with septic shock if they are refractory to fluids and pressors. Although still a weak recommendation, they did upgrade the quality of evidence from low to moderate, given all the literature that's been published since 2015. And so this is kind of our perfect segue into discussing all this literature that kind of sets the stage for the study that we'll be looking at today. So the first study is the Haneen trial from 2002. This was a randomized controlled trial that looked at mortality at 28 days, comparing hydrocortisone plus fludrocortisone versus placebo. This study showed significant mortality reduction in the group who received steroids versus placebo, including both ICU and hospital mortality, with a number needed to treat of 10, which is pretty amazing. However, they did not find a difference in mortality at 1 year. The next trial is the Corticus trial from 2008. This was a multi-center RCT that compared hydrocortisone to placebo and found no difference in mortality between the two arms, but they did find significantly faster times to shock resolution in the steroid arm, and that's kind of where the use of hydrocortisone and steroids kind of jumped off. In the Hybris trial in 2015, which was also a multi-center RCT, the primary outcome that they looked at was septic shock at 14 days, essentially looking at time to shock reversal. And they found no difference in time to shock resolution, and also didn't find a difference in their secondary outcomes of mortality, whether that be at 28 days or 180 days. The next trial is our adrenal trial from 2018. This was also a multi-center RCT with a much larger patient population compared to previous studies. Similar to previous studies, they looked at critically ill adult patients with septic shock and on pressors for over 4 hours, but excluded those who were not expected to survive longer than 90 days. They found no difference in death from any cause at 90 days or at 28 days, but did find significantly faster times to shock resolution and less mechanically ventilated days with those who received hydrocortisone. In the Approaches trial from 2018, which was also a multi-center RCT with a very similar patient population as mentioned previously, they found no difference in their secondary outcome of all-cause mortality at 28 days, but they did find that in patients who received both hydrocortisone and fludrocortisone, there was significantly lower all-cause mortality at 90 and 180 days, with a number needed to treat of 17 for the 90-day mortality outcome. And finally, in the Bosch and colleagues trial from 2023, which was a retrospective cohort study based on the Premier Healthcare Database, which includes about 25% of the US hospitals, they looked at hydrocortisone plus fludrocortisone versus hydrocortisone alone in septic shock. So it's the first trial to really compare combination steroids to monotherapy, whereas all the previous studies looked at combination versus placebo. They found a significantly lower incidence of composite death in hospitals or at discharge to hospice in those patients who received combination corticosteroids, with a number needed to treat of 28. Provided they did give limited analysis on the severity of illness, which meant limited discussion about the pressor requirements that these patients had, or the requirement of mechanical ventilation at baseline. They also had limited discussion regarding the heterogeneity of the septic shock picture that the patients had. Some differences to just denote between all of these studies was the illness of the study population was different across the board. And this is based off of the reported SOFA and SOAP2 scores, the incidence of mechanical ventilation required at baseline, and the dose of pressors that these patients were requiring. There were also some nuances when it came to steroid dosing and durations. Some studies looked at intermittent dosing with our Q6 dosing that we usually use, I would argue, based on my experience, while other studies looked at continuous infusions, and then some studies included steroid tapers, whereas others didn't. The duration of the steroids were differing between the studies, with some looking at 5 days, some looking at 7 days, and some looking at steroids until ICU discharge or death. The timing of steroid initiation was pretty similar across the board. So the thing to note here is that the 3 studies that showed any difference in mortality or reduction in mortality were the studies that looked at combination steroids. And these were a Haneen trial from 2002, the Approaches trial from 2018, and the Bosch trial from 2023. I think this brings to question whether the benefit of steroids in septic shock is only if we were to use fludrocortisone, because we were unable to replicate the results of these studies in any of the other studies. And that kind of sends us into our study that we're going to be discussing today. So the title of the study is Fludrocortisone plus Hydrocortisone versus Hydrocortisone alone as adjunct therapy in septic shock by Locke and colleagues, published this year. This was a single-center retrospective cohort study of patients who were admitted to the MICU with septic shock that was refractory to fluids and vasopressors from March of 2017 to May of 2020. These patients were compared based on the steroid regimen that they had received. Either they were given a combination of hydrocortisone plus fludrocortisone, or they received hydrocortisone alone for their septic shock, and the steroid regimen was left to provider discretion. Patients were excluded if they had received only one dose of corticosteroids, if they were in a shock state that was secondary to a non-sepsis etiology, if they were on corticosteroids prior to admission, and this was defined as 30 milligrams a day of prednisone equivalents or more for 1 or more months prior to the need of corticosteroids in hospital, or corticosteroids that were used for an alternative indication, such as patients who had received transplants, were on chemo, or had COPD exacerbations. The primary outcome was time to shock reversal, with the shock onset definition being a systolic pressure of less than 90 or a MAP less than 65, and that was considered your time zero for all the baseline variables. Secondary outcomes included in-hospital mortality, 28-day mortality, and 90-day mortality. Additionally, ICU and hospital length of stay, duration on mechanical ventilation, and our safety outcomes. Some definitions outlined in the study that I just wanted to set the stage with were the definition for septic shock reversal was a systolic of greater than 90 or a MAP of greater than 65 that was sustained for at minimum 6 hours without the use of vasopressors. Fluid resuscitation was defined as any volume of crystalloid or colloid fluid that was administered in the 24 hours prior to vasopressor initiation. And their first-line vasopressor was norepinephrine as per the guideline recommendations, with vasopressin added on at 0.04 units per minute when norepinephrine was at 0.1 to 0.2 mics per kilo per minute, again, per the guidelines, which primarily came from the VASC trial. And finally, steroids in the patients that received both hydrocortisone plus fludrocortisone, both of those must have been started concomitantly or else they were not included in the combination steroid arm. Antibiotics were also administered in a timely fashion for all patients and were tailored to the suspected infection, and steroid tapers were left up to provider discretion. A total of 653 patients were screened for the study, with 402 of them being excluded. The primary reasons for exclusion were either having received only a single dose of corticosteroids, if they had shock secondary to a non-sepsis etiology, or if they had other indications for their steroids. So of the 251 patients who were included in the study, there was no significant difference between the two groups in terms of their age, sex, reason for admission, or comorbidities, with the most common sources of infections being pulmonary, urinary, or suspected bacteremia of unknown source. The median lactate in both groups was about 3.5, with a median SOFA of 9.5, and about 74% of either group was mechanically intubated at baseline. When looking at the interventions in treating septic shock, the majority of these patients received appropriate antibiotics within 24 hours of the diagnosis of septic shock. There was very similar fluid resuscitation patterns in both groups, with most patients having received their 30 cc per kilo bolus of crystalloid fluid. However, as you see, there was significantly more patients in the combination steroid arm who received colloid fluid additional to their crystalloids. There was very limited discussion as to which colloid agent was used and what the indication for the colloid was. For example, did they experience third spacing that was requiring maybe albumin to pull the volume intravascularly? It's a little bit unclear. When looking at their vasopressor therapy requirements, there was no significant difference in the dose of norepinephrine at which hydrocortisone was initiated. However, numerically, you can see that the dose of norepinephrine was lower in the combination steroid group when steroids were added, which could maybe help us make the argument that those patients were potentially sicker at baseline. There was also no difference in the MAP at which vasopressors were initiated, with a median MAP of 60 in both groups, and no significant difference in the vasopressor duration. However, significantly more patients in the combination steroid arm were on vasopressin at the time of hydrocortisone initiation, and these patients were also started on pressors significantly faster than the hydrocortisone alone arm. Again, kind of arguing that those patients potentially were sicker at baseline. Regarding their corticosteroid regimens, the patients in the hydrocortisone plus fludrocortisone arm had significantly shorter times to first dose of corticosteroids, and with a significantly higher number of patients who received corticosteroids within the first 9 hours of septic shock. The duration of full dose hydrocortisone, which was defined as hydrocortisone greater than 200 milligrams a day, was again higher in the combination steroid arm. And there was no difference in the number of patients who received hydrocortisone tapers between the two groups. When looking at their outcomes, the primary outcome of time to shock reversal, there was no significant difference between the two groups, and no significant difference in secondary outcomes, which included in-hospital, 28-day, and 90-day mortality. As you can see, the end numbers for both 28-day and 90-day mortality are lower in both groups, which is due to loss of follow-up or loss of information for these patients. There was also no difference in ICU length of stay, hospital length of stay, or duration on mechanical ventilation. When it came to adverse effects, in both groups, there was no significant difference except for the incidence of hyperglycemia, which was significantly higher in the combination steroid arm with a p-value of 0.01, which is not shocking given that they received a lot more steroids. Finally, in the multivariable analyses that they completed, they looked at the incidence of in-hospital mortality and characteristics that might be associated with increased in-hospital mortality. So based on their baseline characteristics that they assessed, they found an association for increased likelihood of in-hospital mortality in patients who had end-stage renal disease, on dialysis, and elevated baseline lactates. Shock interventions associated with higher in-hospital mortality were norepinephrine doses at hydrocortisone initiation, the use of vasopressin, and duration of vasopressors, with higher norepinephrine doses and longer pressor duration being more likely to be associated with in-hospital mortality, as it likely correlates to the severity of illness. They did find that the use of a hydrocortisone taper was actually associated with a decreased risk of in-hospital mortality. And the thought here is that if we were to taper off our steroids, we are reducing the risk of sending these patients into adrenal insufficiency because we're taking them off more slowly. So we're not going to see that rebound effect of pro-inflammatory markers and hemodynamic instability. Some limitations to consider is the differences in septic shock management. While majority of the medical management was very similar between the arms, some differences to note are with the patients who received combination steroids, there was an increase in amount of colloid resuscitation in these patients. They had faster time to steroid initiation and started steroids at lower norepinephrine doses. The majority of these patients, a higher number of patients were on vasopressin when compared to the hydrocortisone alone arm. So again, kind of arguing that these patients may have been sicker at baseline and hence we didn't potentially see a benefit in mortality. And given the number needed to treat, as I mentioned in our initial literature review, you could also argue that we would have had to have a much larger sample size to detect any difference in mortality. And finally, as with most retrospective studies, causality cannot be assumed or proven. Given the nature of the study, there's always a high likelihood of bias regarding the agent choice, time to agent initiation, as well as the variability in physician practice, which introduces treatment bias. So the big takeaway here is that there was no difference in time to shock reversal or mortality with hydrocortisone plus fludrocortisone versus hydrocortisone alone in patients with septic shock. So corticosteroids and septic shock have been associated with faster time to shock resolution, but there is limited evidence suggesting a mortality benefit, and optimal time to initiation and duration of corticosteroid therapy remains uncertain. I just wanted to also take this time to reiterate that the mortality benefit that we saw in the previous studies, whether that be the Haneen and the approaches in the Bosch trials, however, only Haneen demonstrated an improvement in 28-day mortality with a number needed to treat of 10. So lack of small number needed to treat in both the approaches in the Bosch trial, as well as no statistical benefit observed at 28 days, could all be due to changes in management of sepsis over the past 21 years. An example of this would be moving away from early goal-directed therapy as per the results of the Process, Promise, and Arise trials. So perhaps the benefit of fludrocortisone or even steroids in general is less profound than we thought, given our current management of septic shock. And with that, I am open to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.